Hello, my name is Leanne Robertson, and I am the team leader for this care management project. Today we are here to discuss chronic obstructive pulmonary disease, commonly known as COPD. The objectives for today's presentation are to be able to discuss and identify the pathophysiology, signs and symptoms, labs and diagnostic tests, therapies, and goals of COPD patients. Our SMART outcomes are as shown. Target audience and team members caring for patients with COPD. The objectives will be reviewed and with a question and answer period at the end of the presentation. Each team member should be able to answer all questions. Learning outcomes will be met by the end of the presentation. All team leaders are healthcare providers with knowledge of patient care. The outcome will match the objectives by the end of the presentation by the question and answer portion. By the end of the presentation, the team members will be able to discuss all objectives listed above. COPD is the third leading cause of death in the United States. It is non-reversible and an incurable disease that affects twice as many women as men. By 2020, it is expected to be the third leading cause of death not just in the US but worldwide. The COPD population is expected to grow to 80 million worldwide in the next 15 years. COPD does not discriminate, but there are risk factors that contribute to its outcome that we will discuss later in the presentation. Along with the struggles COPD brings, most have other comorbidities such as heart disease, diabetes, high blood pressure, osteoporosis, and depression. This can be linked to the effects of COPD, but some are lifestyle related as well. This is an overview of the goals of care based on the national standards. Identify and reduce exposure to risk factors such as tobacco smoke, noxious chemicals, dust, and environmental pollution. Reduce symptoms and exacerbation episodes by reducing overproduction of mucus, decrease mucus hypersecretion, control inflammation, increase ciliary transport, and modify cough. Most of these can be obtained by the proper medication and holistic therapies offered. We will discuss them in later detail of the presentation. There's also the objective of the goal of limiting the impact of an exacerbation by knowing the signs and symptoms of an exacerbation and treating it with the right medications. Improving health status and exercise tolerance through pulmonary rehab, which we will also be discussing later in the presentation. The number one way to hinder the progression and control of symptoms is to stop smoking. Research shows that stopping smoking at any point in the disease is beneficial. Smoking cessation can improve cough by improving ciliary function and decrease airway injury. Limiting exposure to noxious chemicals such as tobacco smoke, first and second hand, dust, air pollution, and harsh chemicals can decrease symptoms of COPD. Vaccinations such as the flu shot for influenza and the pneumonia vaccine are recommended by the chief medical officer. An infection in the chest could lead to a serious exacerbation. Limiting exposure to individuals who are sick and avoiding public places during the flu season are also a good recommendation. Depression screening is recommended by the National Institute for Health and Care Excellence for any person who has a chronic disease that can be debilitating or life-threatening. COPD is an umbrella term that includes emphysema, chronic bronchitis, and chronic asthma. Let's take a look at the pathophysiology of these three illnesses. COPD or emphysema is a permanent enlargement of the air spaces in the lungs and destruction of the alveolar walls. This causes overinflation and reduction of the lung's surface area, which leads to poor gas exchange. Noxious fumes such as cigarette smoke stimulate an inflammatory response, which triggers the activity of cells such as neutrophils, macrophages, and lymphocytes. These cells produce chemicals that lead to the destruction of the alveoli walls and the alveoli. This destruction causes an inability to uptake oxygen and remove carbon dioxide. Chronic bronchitis is an inflammatory disease of the mucous membranes of the bronchi. This leads to increased goblet epithelial cells, gland hyperplasia in the large airway, narrowing of the small airways, and increased resistance and fibrosis around the bronchioles. In chronic bronchitis, the airway epithelial releases inflammatory mediators due to long-term exposure to noxious chemicals or infection. Chronic asthma is an inflammatory disorder of the bronchi. It is caused by the constriction of the muscles in the smooth airway and inflammation of the bronchi. It can cause reversible bronchospasms brought on by bronchoconstriction from stimuli. This stimulation causes the release of chemical mediators such as histamine and prostaglandin. The histamine causes contraction and constriction of the smooth muscles surrounding the airway. The stimulation also induces bronchial microcirculation changes, increasing mucus production, airway narrowing, and obstruction. The combination causes air trapping, hyperinflation, and poor gas exchange. Common symptoms of emphysema include shortness of breath and tachypnea. As the disease progresses, the individual can develop pursed lip breathing, tripod stance, and hypoxemia. These progressed symptoms are due to an increased level of carbon dioxide trapped in the lungs and lack of oxygen. Common symptoms of chronic bronchitis are cough, increased mucus production, dyspnea, wheezing, fatigue due to work of breathing, and hypoxemia. Chronic bronchitis patients are often referred to as blue bloaters because they have edema due to right-sided heart failure. Common symptoms of chronic asthma are trouble breathing, wheezing, cough, and chest tightness. Due to the nature of the disease, although different from emphysema and chronic bronchitis, asthma is also classified as an obstructive disease. Some other common symptoms of COPD are noisy breathing, finger clubbing, and use of accessory muscles. An assessment of the patient should include vital signs, oxygen saturations via pulse oximeter to see their level with or without oxygen. Should listen to the lung sounds, and you would expect to be able to hear shallow lung sounds due to poor recoil, crackles present due to increased mucus, and wheezing due to constriction. The heart tones could be tachycardic due to work of breathing. Edema could be present due to the right-sided heart failure or congestive heart failure, a common comorbidity in COPD patients. Checking the circulation of the nail beds could be sluggish due to poor oxygenation. Assess the patient for exposure to noxious chemicals such as excessive dust or cigarette smoke, past and present. Ask the patient about sleep habits. Can they sleep lying down, or does it have to be sitting up due to shortness of breath? Do they get fatigued participating in daily activities? Have they noticed a decrease in stamina with exercise or daily tasks? All this information helps you to assess the risk factors they have and the degree of their COPD. Some of the treatments for COPD, the medication treatments, are long-acting B adrenergic receptor agonists. They reduce hyperinflation and increase peak expiratory flow, allowing for an effective cough. Anticholinergics help mucus clearance by increasing luminal diameter and decreasing mucus secretion. Glucocorticoids help reduce inflammation and mucus production. Inhaled corticosteroids reduce the frequency of an exacerbation. Phosphodiesterase 4 inhibitors increase inflammation and relax the smooth muscle and can help reduce the frequency of exacerbations. Antibiotics are beneficial for COPD patients experiencing an infection. COPD patients have a compromised immune system due to the disease process and also from medications like steroids. Respiratory infections can bring on an exacerbation that can be life-threatening. Oxygen therapy is used to treat hypoxemia and not breathlessness in COPD patients. Careful consideration must be used when prescribing oxygen to a COPD patient. Too much oxygen can lead to an increasing hypercapnia and decreased drive for the patient to breathe on their own. There are key tests used to determine the presence and severity of COPD. Patients usually start with a pulmonary function test known as PFTs. PFTs consist of spirometry that measures the forced vital capacity and the forced expiratory volume. This is done by blowing into a mouthpiece with the tubing attached and blowing as hard as possible. This test can detect COPD severity even before the symptoms start. Other tests performed are chest x-rays or a CAT scan of the chest. These images allow the provider to see the anatomy of the heart, lungs, and blood vessels and rule out any abnormalities. Arterial blood gases are performed to check the amount of oxygen in the blood. This test can indicate the severity of COPD and also show the level of carbon dioxide in the blood. Some holistic therapies are supplements such as omega-3 fatty acids. They have been shown to reduce inflammation and work of breathing. Vitamin E has been shown to improve lung function. Antioxidants help reduce stress and inflammation. It is found in foods such as red grapes, green tea, broccoli, and tomatoes. There is also yoga, and that teaches the individual to listen to their body, take deep breaths, and improve their lung expansion. Yoga can be done at a slow pace that does not exert an individual's lung function and also gives them some exercise. Pulmonary rehab incorporates many therapies to help an individual reduce COPD symptoms and live life. Some of the major therapies offered are education on breathing, exercises, muscle strength, and nutritional advice. There are often several psychological and psychosocial therapies available to COPD patients as well. Some collaborative objectives that I would like to discuss. Some come from the Healthy People 2020. Healthy People 2020 have set objectives for the COPD population. Reduce activity limitations in adults with COPD, reduce deaths from patients with COPD, and reduce hospitalizations and ER admissions to COPD. In order to reach these goals, we as healthcare providers have the responsibility to see that each COPD patient has the right information and supplies they need to live exacerbation-free at home. Some ideas for this collaboration of care are a discharge criteria. Patients must be able to use long-acting bronchodilators, inhaled short-acting beta-2 agonist therapy that is required no more than every 4 hours. If the patient was ambulating before admission, they must be able to ambulate before discharge. Patient must be able to eat, drink, and sleep without frequent episodes of dyspnea. Patient must be clinically stable for 12 to 24 hours, including stable arterial blood gases. Patient and family or caregiver must understand the correct use of home medications. Follow-up home care arrangements have been made, and the patient, family, and physician are confident that the patient can manage successfully at home. Also, a checklist of home equipment and supplies needed at home before the patient discharges. Assure patient has an effective home medication regimen. Patient and caregiver understand and can demonstrate inhaler and nebulizer techniques. Proper instructions have been given to patients and family on steroid therapy and medications. All oxygen equipment has been delivered and instructions on use have been given. Assure all follow-up appointments have been made. At the discharge appointment, the responsibility of the physician is to make sure that the patient has the ability to cope in their usual environment, a measurement of the FEV1, reassessment of the inhaler techniques, understanding the recommendation treatment regimen, reassess need for long-term oxygen therapy and or home nebulizer, assess capacity to do physical activity and activities of daily living. COPD is a serious and fatal disease that affects millions of Americans. It is our job as healthcare providers to give these individuals everything they need to maintain their lifestyle at home and avoid exacerbation. This is a collaborative effort that involves you, the patient, and the family. Thank you so much for your time. Now we will take time for the question and answer portion.